sunny evening whereby we've had so much sunshine, and I for one am really exhausted. I'll tell you why. This gardening business, I find gardening very therapeutic. So I take a great interest in planting flowers, various flowers, those that are perennials, which are those flowers that are long lasting for those of you who aren't gardening geeks. And I found that I've taken a great interest in things and flowers and plants that help with bee production as well, and to help with multiplication of bees. As we know, bees are very important to our environment, and today there was supposed to be a bee counting session that was headed by Channel 4. I couldn't make it, but I've tried to make my garden a haven for bees. And it's so wonderful sometimes just sitting in your garden and looking at these little bees coming and collecting nectar and pollen from the flowers. So I've been doing a bit of gardening today, and I'm absolutely knackered as a result of it, but I still wanted to bring myself over here, and I hope you've all had a wonderful week. The children are about to break up from school for their summer holidays, and I wish and I hope that you're all looking forward to your summer holidays, because indeed I'm sure that you all deserve it. And it's just been a wonderful, positive week all round, and I hope the way my week has been positive, yours has been positive as well. What have you all been up to? It'd be good to know. If you want to comment underneath my show, it would be wonderful for you to tell me what you've been up to during this week, how you've stayed out of the sun. The temperatures are quite hot, although not that bad. In the evening it gets a little bit more chillier, but during the course of the day it does become quite hot. So what are you doing to keep yourselves healthy, hydrated? What type of things are you doing? It'd be wonderful to find out. So I'd like you to join us in our show, because we've got a very special show, as we always do every week. So I'd like you to text me or WhatsApp me on 07745 278 978, or you can ring us on our studio telephone number 01733 602 133. Or indeed, you can watch us on YouTube Live, Facebook Live, Twitter Live, and we've also got Instagram as well, which I found was really quite innovative, of Salaam Radio, and I hope it continues this way as well. So, without further ado, tell me a little bit about what you are doing over this week, what your plans are for the summer holidays, what things you're doing to become healthy. And it's an absolute pleasure to introduce my guest for this week, and she is somebody who is a consultant neurologist. Her name is Dr. Hina Abbasi, MRCP. She has done a general medicine, an SCE, which is the name of a qualification in neurology. So she's a consultant neurologist at the Institute of Neurological Sciences at the Queen Elizabeth University Hospital in Glasgow, UK. She's also a research fellow in epilepsy, status epilepticus, at the University of Glasgow. So it's wonderful to bring her on board, and I'm going to introduce you to her. So we're going to bring Dr. Hina Abbasi on board and say Assalamu alaikum. Dr. Hina, Assalamu alaikum.
Walaikum assalam. Thank you so much for your kind introduction.
Of course, well, you're very deserving of that kind introduction, because Dr. Hina, you and I go back a very long way, don't we?
Yes, actually, I still remember our A&E shifts together in West Middlesex, London.
Yes, It was wonderful, because I wanted to share today with all of my listeners how actually our relationship, mashallah, has been maintained throughout the years. We've still been in touch, mashallah. We're in touch via social media. That's more than any other portal. But I'd like to tell my listeners that Dr. Hina Abbasi and I both worked at the Accident and Emergency Department of the West Middlesex Hospital in London. And I was expecting our first at the time, and I would always meet Dr. Hina at the bus stop, and I would get onto the bus and you would be sat there on the bus and we would be talking, and I will tell you that she's got two beautiful daughters. And at the time I remember getting onto the bus, there was a gap where I hadn't actually seen Dr. Hina, and I got onto the bus and I saw that Hina had mehndi on. So I said, what's all this about? And she said, oh, I just went back home, and the day I got back home it was the day of my mehndi, so I put my suit on and everything, and I got married. Do you remember?
It was so sudden, actually. I just remember it was my day of my interview in Cardiff as a foundation doctor, and I told my mom, really, I don't care about Mehndi or Shadi, whatever. I just really want to get this job, to get into the career ladder. So basically, if go ahead with whatever you're planning, I'll get there by the time Nikah is being done. But I don't care about nitty-gritty of other wedding celebration. Everything else is meaningless for me. And yeah, that's how it was. So I managed to get to my Mehndi. Otherwise, plan was my younger sister will sit in and pretend to be me, and all that.
Oh,
so I think I did a bit of a drama for my wedding, but it was all, I think at that time career, and I wasn't ready to compromise my life or my dreams for purely, like shadi ke liye.
Yeah.
But it both turned out to be very, successful in life. My shadi and my career both. Alhamdulillah, Allah has really helped me with that.
Alhamdulillah, that's wonderful. But that was the most turbo wedding I've ever seen in my life. So that's how. And from there on, mashallah, it's wonderful. Our families have grown. Your career has taken you to Glasgow, where you are an extremely credible neurologist. And it's wonderful, alhamdulillah, to stay connected to you, Dr. Hina. It really is. So would you like to tell our listeners a little bit about why you chose this speciality in the first place?
Actually, basically, I really was intending to do something acute medical and gastroenterology, something, ICU medicine, something really acute, but yet hospital medicine. But when I actually got to the point where I was in year 4, where you decide your subspecialist interest, I realized that all these specialties that I've experienced so far, ICU, anesthesia, gastro, cardio, if you were a female and if you wanted to, grow a career in that, and it was a lifelong commitment with kids and with family, I would struggle because you have to be part of acute medical receiving rota. So at that point, it hit me that I need to choose a specialty which is interesting enough, challenging enough for a woman that, being a female neurologist, a very, very, very few female, especially from Pakistani and especially from Muslim background. So it will give me that kind of challenge to do something unique and less of an interest for general physician from Pakistani origin being a female. But it will keep me in hospital medicine. So both things, the में थी, and I chose something like neurology and dermatology or oncology, where you don't have to be part of general medical receiving rota, but yet you are doing something which really satisfies your interest. So I applied for these 3 as a top of my interest when run-through application came through, and I got selected for neurology with no experience, but I think I scored really high in my interviews and assessments. Right? So, that's how it all started. Initially, it was quite a challenge to take because I'd never done a neurology job as a house officer or as an ST trainee. But eventually, alhamdulillah, it's been years and years of just doing neurology and then subspecialization. And it just shows that if you work hard and ready to take challenges, and Allah helps you, and then you get to where you want to be.
That's absolutely right, and you are a prime example of that. I'd just like to make my listeners aware at this stage that Dr. Hina, we usually have a video of the people that we interview who give their valuable time, and at this point in time, Dr. Hina has travelled from an awful long way from Cardiff, and she is on her journey, and she was held up in traffic, but has still been so kind enough to speak to us via telephone. So we are so grateful to you, and hopefully inshallah after the break we'll get you set up on the camera, hopefully if you reach home by then, and we'll be able to speak to you via video as well, so that our listeners can observe the interview as well as listening to it too, which I think would be wonderful. Now, Dr. Hina, we know that you're doing a fellowship in status epilepticus, which is, what's status epilepticus for purposes of easy language for our listeners, please?
Status epilepticus is a condition which usually presents itself as recurrent seizures which do not stop by usual meanings of giving buccal midazolam or seizure stopping medication in general term, if I want to use. If it lasts then more than 5 minutes, any seizure which is affecting whole body, and if it lasts for more than 5 minutes, it is defined as a status epilepticus. It's a life-threatening condition with a very high mortality and morbidity associated with it. So this is something that I am researching on, and trying to have some population-based study to see outcomes, mortality, morbidity, treatment, and long-term outcome. Actually, what has happened to these people when they recover from ITU? Because usually status epilepticus patients need to go to ITU. They get intubated, ventilated, so they are on life machines in layman term for maintaining their airways and stuff. So it's a very serious condition. One of the most worrisome outcomes of someone with epilepsy, and the treatment is ever evolving. Therefore, more studies are needing to be done to help clinicians decide best course of action and management for the patient.
Right, okay. That's very well put, actually. Now, if you already joined and tuned in from Peterborough, this is the Body Health and Mind Show. I'm Dr. Shabina, your host today on today's Body Health and Mind Show, as I am every week. And I have with me Dr. Hina Abbasi, who's a consultant neurologist in Glasgow, who's kindly given her time to speak to us. So, for purposes of, because these programs are really quite simple, they are for information for our listeners and to signpost them as to where they need to go in terms of various conditions. What is epilepsy defined? What is epilepsy itself, Dr. Hina? What would you define epilepsy as?
Epilepsy is a condition in which there is abnormal brain discharge. Every human being is producing brain waves all the time, even when they're sleeping, when they're awake, when they're eating, drinking. No matter, a live person constantly produces brain waves as they live. So when there is abnormal discharge, it means the discharge is more than usual, and it kind of spreads all over the brain. It produces abnormal motion, abnormal activity in the body. So patient gets jerks and they get convulsion in medical term. Their whole body goes into spasm, and then they can have myoclonic and tonic phase. This is one type of seizure, though. Seizure in general can be of 60 different types. Epilepsies can be of 60 different types.
Wow.
Based on different types of seizure one can experience. So not everyone who has abnormal brain discharge means epilepsy has full-blown seizure with body jerking. Some only have a staring episode. Some have loss of speech. Some have loss of time, just sitting and staring, doing nothing else. Some have myoclonic jerking, just muscle twitch, but nothing more than that. So there are many, many types of seizures and 60 different types of epilepsies. But in a layman term, the one people must have seen and appreciate as a seizure is the one where patient falls, whole body goes rigid, and there is stiffening and jerking for a few minutes. This is an abnormal discharge of brain wave, which is not expected or normally produced in normal conditions.
Okay. Well, that's been explained very clearly to our listeners. So in terms of electrical activity in the brain, there's a level of normal electrical activity in the brain. So when there's an abnormal discharge of activity, that can manifest as some form of seizure. Now, for purposes of our listenership, yet again, what are the causes of epilepsy?
Okay, epilepsy is it has many causes. Some people are born with genes. It runs in family. There is a huge gene pool which has been investigated. We have developed genetic panels where we know thousands and thousands of genes have been identified leading to epilepsy. In where I work, we have 107 gene panel which we test for everyone with a family history of epilepsy or where we suspect there is a genetic cause for it. So genetic cause is one very significant factor. Then people develop epilepsy after trauma. For example, someone had a road traffic accident or a fall or a birth-related injury, and the part of the brain is damaged. And because of that damage, there is a scarring in the brain, and that scarring leads to abnormal discharges because flow of normal current in the brain is not there, and there is a structural problem in the flow of brain waves. Then people have epilepsy secondary to metabolic problem. For example, some people are born with abnormal metabolism. They have GLUT1 deficiency, or some people have chromosomal abnormalities. Some people have learning disability. Some people have Down syndrome, Alzheimer's. So there are neurodegenerative conditions where brain over time degenerates or stops functioning in a normal way, and hence people develop epilepsy. So epilepsy can be symptomatic when you know there was an incident, for example, road traffic accident or head injury, and then develop epilepsy. Then they can develop epilepsy genetically, which is called idiopathic. It means that there is a gene for it, and they can be cryptogenic, where we suspect there is a problem with gene, or maybe we know the cause, but yet science has not evolved enough for us to be able to give patient a definite diagnosis or label of the cause of epilepsy. So there are many, many causes, but I have just tried to give you the three different type of main categorization of epilepsy: genetic, symptomatic from any incident like trauma, head injury, whatever, and cryptogenic, where we know something is wrong, but science has not been able to answer it.
Right, okay. Well, that's, again, very interesting. In my experience as a GP, have noticed that there are quite a few people with learning disabilities, and those that are on the autistic spectrum as well, that are severely autistic, can be subject to seizures. And in fact, a lot of them have irretractable seizures, whereby controlling them can be very difficult. And I've got a question in relation to this, if I may, a bit more later on. But it's important to realise now, is there any prevention that can take place, or anything at all that one can do to prevent seizures? Obviously, head injury is one thing. Drugs, taking of drugs, illicit drugs, etc., or withdrawal from medication, is that known as a established cause?
Definitely. We have people who develop epilepsy secondary to chronic alcoholism or drug abuse. This is usually if someone has a seizure. For example, they come to my clinic and they had a seizure after alcohol withdrawal, or after taking lots of cocaine, or whatever drug, diazepam overdose or chronic diazepam abuse. Then we don't treat them as epilepsy. We don't label them as an epileptic, because we know there is a provocation, and we know there is a substance which is inducing seizures. So by definition, people who are on medication or are taking drugs which can cause seizure or lower the seizure threshold are not labeled as epileptic, unless they have been using it on chronic basis on like years and years, and then they have although stopped taking drugs, or they have stopped using alcohol in excess, but they continue to have seizure because of the acquired brain damage over the years. In that sense, we call them epileptic, but we label them alcohol-induced epilepsy or drug-induced epilepsy. So epilepsy can occur in people who are ex-alcoholic or ex-drug-induced, but if there is ongoing intake of alcohol and drugs, we don't treat them as an epileptic, and we don't call them as epilepsy. We call them provoked seizure. Okay. So these are the ones that they have a better outcome if they stop provoking or stop using the substance that is leading to low seizure threshold. These are the people who do really well. Actually, in long term, there is a hope that they don't need to be on long term anti-epileptic medication, and their brain, stop seizing if they look after their health in general and avoid provoking substances. Otherwise, prevention in general for people who are not taking these kind of stuff. To be honest, if someone is born with the family history of epilepsy, the mother is epileptic, or 2 or 3 siblings are epileptic, in these people, they can't do much to prevent it. They can live a healthy lifestyle, avoid substance abuse, avoid sleep deprivation, tiredness, and things like this. But if seizure has to happen, it will happen. And there is a strong genetic link in people. We have studied families and families of people who have seizures, and who have mother or sister or brother affected with a similar condition. So, for genetic conditions, so far science is not advanced enough for us to be able to tell them, oh, if you did not take this or if you did that, you will be seizure free. For symptomatic ones, where there is an incident or an effect to the brain due to an external trauma or infection, for example, somebody has herpes encephalitis or brain infection, if they develop scarring on the brain, this is not something that they can prevent. It's better not to have the condition, but if the scarring has happened and there is a focus for epilepsy, these people eventually, unfortunately, will develop seizures. Yes, we can control their seizures with medication, but prevention isn't something that is possible with genetic condition or in generally in most cases, apart from where there is a substance abuse or a medication. For example, some people can have a low seizure threshold from hyoscine patches or from psychotropic medication. So in those cases, if you withdraw that substance, then there's a hope that next seizure will not happen. But not really prevention is something that we can advise on.
Yes, absolutely. Well, that was really all very interesting. Now, coming to our signs and symptoms, obviously you deal with adult, the aspect of epilepsy. What are the things to look out for? What are the signs or the symptoms that one would feel if they were about to go into a seizure that would be later on diagnosed as epilepsy, as I'm understanding that you can't diagnose epilepsy on the basis of one seizure?
No, actually, I have had patients who have come to me with a single seizure, full-blown generalized seizure where body goes stiff and they're jerking, frothing from the mouth, tongue biting, incontinence. So I'm quite confident that these people have single seizure. And majority of the cases, I don't have reason to treat them because we know that 70% of these people will not have a second seizure. And in general population, every 100%, 1% in every 100 patient that we see can have a single seizure in life. That doesn't mean that everyone who has a single seizure will develop epilepsy. So we take single seizure as a kind of a separate issue. But when it comes to risk of developing epilepsy, there are things that I look for. For example, I ask everybody about the family history. If patient has first-degree relatives with epilepsy, I know they have a higher chance of having a second seizure. If someone, for example, has myoclonic jerking in the morning, which normally people do not appreciate as epilepsy, whereas someone just twitches, they have for example, they're holding a cup in their hand and cup suddenly jerks, and it is for a second there is a jerk and then nothing happens, they don't lose consciousness, there is no loss of awareness. This is significant for me because that is seizure for me but not for general population. So a lot of the time I have to inquire a lot about these kind of symptoms from my patient. These happen mainly in the morning or in sleep or particular time of the day, and if they give me this history with a single full-blown seizure, I am pretty confident that this person has a high risk of developing further seizures. So if someone says, I had a history of febrile seizure, I would take it quite seriously because febrile seizure to me is a huge risk factor for developing epilepsy. So 6 to 7% of patients who have febrile seizure as a child will eventually develop epilepsy as an adult. So there are clues in the history and family history which help me to risk stratify, and if patient has more than one or two risk factors, I advise them or guide them that you have had one seizure which I'm confident about, but there are things in the family history which make me feel uncomfortable, so your risk of having further seizure is more than general population. And some of them choose to go on anti-epileptic medication because driving is an issue, job is an issue, and they're so frightened, and majority on the other hand say, well, we only had one seizure, we don't want to commit to lifelong anti-epileptic medication. But as an epileptologist, that's my job to risk stratify patient, to pick up the individual clues from the history which make me feel that this one is low risk or the other person is high risk, and then based on that information we have a discussion about treatment.
Okay, well that was very succinctly put, Dr. Hina. So giving us the various type of options and how obviously this can impinge and what changes one has to make and how you would then analyze the history of an individual to come to a conclusion whether this is epilepsy or not. We're coming up to obviously a break in another 2 minutes time. So generally, after a first seizure, would you advise everybody to go to their GP first of all? It needs to be investigated and then to be referred to yourselves?
Everyone who has a single seizure needs to see a epileptologist. Pathway is they can bypass GP if, for example, they attend A&E with a single seizure. Majority of the time, ambulance are called. Patient is blue lighted to the hospital with seizure when they're seizing. Hospital stabilizes the patient. Usually do the ABC like blood sugar, routine bloods, ECG. Make sure it isn't arrhythmia or heart condition leading to reduced oxygen to the brain, leading to seizure-like activity. Making sure patient does not have alcohol related issue, making sure they're not hypoglycemic, like low blood sugar in the blood, so they have to rule out few basics. Once they have done that, and it is established that they definitely had a seizure, there is a seizure pathway. So, for example, where I practice, we have forms which are filled by A&E staff, and they are faxed to us, and we then vet the patient to the clinic directly. So in that case, not everyone needs to go to GP, but some people will attend GP and then of course come to you, and then
we'll join you after the break, Dr. Hina. Please join us after the break.
Okay,
thank you.
Stay tuned to Salaam Radio after this short ad break.
It doesn't take much to bring some difference. You give some change, which makes a change. Because nothing gets mileage like a charity. Just a little change turns into a chain. And before we know it, the results are massive. So give a little to make a big difference. For donations, call now. UKIM 0207 387 2157.
दोस्ता कियां परेशान है
जरा कर है ना सारा सौदा मुक्या वा मुल्का विच पैसे भेजने
हूं नहीं मार फूड वाले की फोन खड़का ते फ्री लोकल डिलीवरी कार मंगवा
आला ता उथे कै स्पेशल आ
उना की लबई हाइजीन च ग्रेड 5 चीजें चंगियां मियारी ते सस्तियां ते नाले ऑफरां ही ऑफरां
और क्या
ताजा गोश्त ताजी सब्जियां ते फ्रूट आटा चावल दालां मसाले ते जूस सारे बिल जमा करने गैस ते इलेक्ट्रिक ने टॉप अप भी करने पाकिस्तान पैसे बिल्कुल फ्री भेजने मतलब के एक चिड़ी ने दूध छड़ी ते हर शय लबनी
और जने ने आप उतरा
Amar Food Store and Halal Meat 613B Lincoln Road Peterborough telephone 01733 687374.
My name is Khalid Siddiq.
I'm Saif Adam.
Salaam alaikum, this is Baraka Blue.
Yo, this is your boy Harris J, and make sure you guys stay tuned to Salaam Radio 106.2 FM.
Salaam Radio, in conjunction with the Council of British Hajis, presents a Hajj seminar Sunday the 21st of July from 1 p.m. at the Allama Iqbal Centre, 157 Cromwell Road, PE1 2EL. Multimedia guide presented in English by Sheikh Suleiman Ghani and Abdul Akbar. Learn how to perform Umrah and Hajj. Practical guide. Interactive Q&A. Health and safety advice. Hajj travel shop. To book your tickets, visit cbhuk.org/events or call 0845 833 4145. Hajj Seminar, Sunday the 21st of July from 1 p.m. at the Allama Iqbal Centre, 157 Cromwell Road, PE1 2EL.
Do you own a restaurant or takeaway? Cater Fair is an expert supplier of new and used commercial catering equipment. Visit caterfair.co.uk for quality equipment on sale at the lowest prices, or call us on 01733 310 115 or visit us at 11 Royce Road, Fengate, Peterborough.
Gems and jewels. Wise sayings, interesting events, and moral lessons from Islamic history. The Uthmani ruler and the old woman.
It has been related that an old woman entered the hall of the ruler Suleiman al-Qanuni, complaining to him about his army that stole her livestock while she was sleeping in her house. The ruler said to her reproachfully, "You should have stayed up and taken care of your livestock." She glared at him and quickly responded, "I thought that you were awake, watching over us, my leader, and so I slept with a peaceful mind." The ruler said, "The truth is with you."
Did you ever hear
Broadcasting 24 hours a day, 365 days a year. This is Salaam Radio.
Assalamu alaikum, welcome back. This is Dr. Shabina Asad Qayyum for Salaam Radio 106.2 FM and the Body Health and Mind Show. Today on Salaam Radio 106.2 FM in Peterborough, and the UK wide and nationally and internationally as well. It's wonderful to have you. We have just been speaking about a really important topic in regards to a neurological condition which is known as epilepsy, which our wonderful guest, Dr. Hina, who's travelled all the way from Cardiff to Glasgow, has been speaking to us on her journey, which is very kind of her to give us her time. And she's actually a general medicine and a neurological consultant at the Institute of Neurological Sciences at the Queen University Hospital in Glasgow, UK. And she's a research fellow in epilepsy, which is status epilepticus, which she explained was having recurrent seizures. And we're trying to get her hopefully onto our video because we've just connected so that we can see her. It'd be wonderful once we have her on, and if there are any issues with the sound, then we will revert to mobile phone. But she's just been telling us before the break what the causes of epilepsy are. Do have a look back on this show, what the causes of epilepsy are and what the signs, symptoms are. She told us there are 60 different types of epilepsy, which is astounding really if you think about it, and obviously gave us a little bit of background of the association with genetic links and epilepsy too, but a family history. And actually one thing that I learned, which I was very surprised about, is that if a child has febrile convulsions, they have a 7% chance of developing epilepsy in later life. So, Dr. Hina, are you with us?
I can hear you.
Oh, that's wonderful. Dr. Hina, can you hear us? You're with us?
Yes, I'm with you.
Oh, that's wonderful. I hope you've got comfortable now.
I'm fine, actually. I was just in the traffic and unexpected delay of an hour, so that's fine. I'm home now.
Oh, bless you. Bless you. Well, hopefully, inshallah, there's only half an hour left, so we will then leave you be. But thank you so much once again for your time. And I'm very interested in the point, Dr. Hina, where you said that 7% of children who have febrile convulsions would go on to develop epilepsy at some point in their lifetime. Do you know what possible linkage that is? Is it because the brain starts abnormally discharging electrical impulses at such a young age that it could develop the potential for abnormal discharges of electrical waves later on in life?
Basically, it is genetic. It is a provenly genetic cause. Majority of these children or these babies have a mutation in 2 or 3 different genes where they are born with tendencies to have seizures.
Mm-hmm.
Initially, it is unmasked by infection and febrile conditions. We don't treat them as epilepsy because majority of these cases, like 97 or 95% of these cases, will not develop epilepsy in long run. But minority, 5 to 7%, if they have more than 2 febrile seizures in childhood, will develop seizures. So in my history taking, when a person comes in adult life, as I'm an adult neurologist, and they have seizure, even if it is a single seizure, but there is a family history or a history of febrile seizure in their own case, I take it as the person who with a slightly high risk of developing long-term epilepsy or maybe having more seizures. So it is relevant. Febrile seizures in his history of epilepsy or diagnosis of epilepsy are not irrelevant. I take them seriously and I put them as a differential for someone who has maybe higher tendencies than general population for developing further seizures. But it is genetic.
Okay, well that's very interesting, that source of information, it really is. Now, we've spoken a little bit about possible reasons and signs and symptoms, etc. Now, you have a patient that is coming to you and you put them on a regimen of medications, and I've seen some of the letters that neurology sends to us. Some of the medications can be quite difficult in their dosing regimen, because you change it on a weekly basis in order to optimize that medication. So how do you decide what medication to initiate on what patient?
It's a science and art, to be honest, and it's a very thoughtful process because there are numerous anti-epileptic medications with numerous side effects, and we have to look at individual patient profile. For example, I would never use valproate as my first choice on a female or of child
Of
because
course.
of the effect. For example, I would never use carbamazepine for generalized epilepsy because it is a treatment for focal epilepsy. If I have someone with headache and seizures, my first choice might be Topamex because it's an anti-headache medication and anti-epileptic. If someone is depressed and is epileptic, I might choose pregabalin or maybe lamotrigine because they are mood elevator, but they are anti-epileptic as well. So if someone is obese, I would not give them valproate. I'll give them Topamex. If childbearing women comes with risk, or concerns about fertility or future pregnancies, I'll probably give them levetiracetam, Keppra. But if someone is depressed, then I would probably not give them. So basically, I have a whole profile of anti-epileptic medication, then their effects, then their side effects, and then I have a patient in front of me. I'm looking at their gender, their age, their fertility, their bone health, and their mental health, because all these medication affect on the brain as well. And then I'm making a decision on individualized basis. So there isn't kind of a flow chart that fits everybody. We have to pick and choose the best medication based on classification, side effect profile, and patient profile. So it's a very individualized process.
I can definitely see that because you've given such succinct answers. So depending upon, it's just looking at the person as a whole. So if they suffer from depression, you give them a particular type of medication or avoid a particular type of medication. The same with sodium valproate, which is something that us in primary care have to now audit to see if we have any epileptic woman of childbearing age who may be on sodium valproate, and thus then have to take her off it or take advice from the neurologist as to what to put her on. So extremely pertinent points that you have put forward in terms of initiating medications and how you would actually do that. Now, one thing that I would like to possibly touch on is somebody's just sent me a text message saying that I'm a medic in primary care. I would like to ask you, as medics, if somebody is under the care of a neurologist but has learning difficulties and intractable seizures but not very old in age, we're looking at under 30 years of age, is lorazepam a suitable medication to give for status epilepticus or regular frequent seizures that take place on a daily basis, and for how long? Would we be worrying about taking this patient off lorazepam in the near future, or is it suitable to put that patient on it long term? Quite a long question, but I think is quite thorough.
To be honest, again, we have to look at the whole patient profile, seizure frequency, type of seizures. If someone is only having complex partial seizures on daily basis, even if they're 50 plus, I wouldn't give them regular benzodiazepine because the risk of life from regular benzodiazepine is more than complex partial seizure, where he's just sitting, losing 30 seconds or 2-3 minutes every hour, maybe 2-3 times. So for those kind of seizures, I would not put them on anything regular. I'd probably just optimize the regular anti-epileptic medication, but not use benzodiazepine to kill these seizures. Whereas if someone is having generalized seizure, which are risk to life on frequent basis, and is falling to ground, jerking and turning blue, and he has drug-resistant epilepsy and it's got burnt-out epilepsy with a condition where we know there isn't a cure, learning disability, or some sort of genetic syndrome like Dravet syndrome or Lennox-Gastaut syndrome. In those patients, we have a epilepsy protocol, which is usually formed by ourselves and epilepsy nurses specialists, and we work between ourselves, patient care, and family. And usually, we don't use lorazepam as a breakthrough medication for seizures. We advise buccal midazolam because it's much safer, mode of action is much better, and is more effective. And you don't need to give IV or, because lorazepam usually is given IV, so you have to have IV access for these kind of patients. Buccal midazolam, whereas you can actually just put into the mucosa, it kind of gets absorbed, and it is, you don't have to go into back passage or intramuscular or IV, so it's kind of less traumatic for the patient or the person who is giving it. So if someone has to have a regular or maybe frequent benzodiazepine, I would prefer to have a discussion with their epileptologist, if I was a patient or their carer, I would like to have a epilepsy protocol made with the help of epilepsy nurse specialist. I will have a clearer understanding of as to how many times per day, after how many seizures per day, this medication should be given. I would then have a cap on number of times this can be given over 24 hours, because there is a risk to life in terms of breathing and heart and hypertension with benzodiazepine overdose. And this can very actually frequently happen if the patient is going through nursing staff and in care houses or being looked after by someone who is not medically trained. Or has not been given training in giving these medications. So lorazepam is not usually my go-to medication for frequent daily uses. If we have to choose a benzodiazepine, buccal midazolam is ideal. Protocol, as I said, can be shared care with the epileptologist, the GP, and epilepsy nurse specialist. This isn't something that I would expect a GP to deal with. If patient is needing that level of care and that much benzodiazepines per day on frequent basis, then this is something that should be under the tertiary care hospital setup, and they should advise GP as to what to do. Usually, I have done this, dealt with this kind of scenario by giving patient actually regular clobazam. Clobazam is my go-to medication. If someone is benzodiazepine sensitive, in a sense that their seizure responds to benzodiazepine, instead of giving them boluses of PRN rescue medication every so often, I put them on 10 or 20 milligram per day of clobazam. It works really well, especially for seizures of all types, maybe generalized or complex partials or nocturnal seizure, because it's a nocturnal medication given at sleep. So if someone actually needs benzodiazepine, my choice in summary would be buccal midazolam with the protocol ascribed to it as to how and who gives it, when you give it, when to stop it, when to consult hospital. And if anti-epileptic medication in the form of benzodiazepine needs to be given regularly, and if the oral intake is intact or is possible, then I would choose clobazam over anything else.
Okay, well, thank you. That's been quite informative. And the colleague has responded back and says that we have a very complex patient who has multiple learning difficulties, and we have found that they have remained on lorazepam and it's being requested for by the primary carer. It is very difficult for us to gain access to the local neurologist because there is a community team that tends to liaise with the patient. But thank you very much for your advice. So that can pose sometimes as a bit of a challenge as well, isn't it, when you can't actually get hold of the consultant, or we have community teams as well. I would expect the community team would definitely relay that information back, though, isn't it?
There are lots of gaps, though. I'm not surprised, to be honest. I see a lot of the time what happens is patient is diagnosed with epilepsy as a child, and they have chronic burnout epilepsy, having 50 plus seizures a day. Family tends to cope with it somehow, and they start living with it, and then GP gets used to treating and consulting, dealing with the consultation every now and then. Somehow the transition quite doesn't happen between pediatric services and adult services, and patient loses that consultant input from adult services, and somehow it becomes problem of a GP to deal with this kind of situation, which is unfair because it's a very, very difficult condition to be managed by a GP on their own. You need to have a consultant-led service advising GP to provide the best care. But the problem in UK is that we have maybe one neurologist for maybe 150,000 patients. So I don't know the exact figure, but we maybe have a handful of epileptologists. Even neurologists are very rare. Epileptologists are even rarer. In maybe Glasgow, where I work, for a 1.5 million population, we would have 5 or 6, maybe 4 or 5 epileptologists in total.
Wow.
So the burden on adult services is huge, and you do see that we struggle to cope, and this is why we end up seeing and discussing these kind of scenarios. So I'm not surprised. The thing I would say is that if someone has learning disability and has frequent seizures on a daily basis, one thing primary care physician must know, or maybe should have more knowledge about, is that there are conditions now we know about which we did not know about 10, 20 years ago when these patients were kids. So, For example, only last week or 2 weeks ago, I saw someone with 50 plus seizure, mental regression, physical regression after normal birth and normal growth up to 5 years. And they came to me after 10 years in primary care with the horrendous amount of seizure. Family somehow. And when they walked into the clinic and they said, "We've been sent by our new GP, who is very enthusiastic. What can you do for us?" And the next thing I had to say to them was, "Give me the history." And I realized that this patient actually had their first seizure after a vaccination for measles or I don't know what, and they had a fever, and that was the start of their epilepsy. So I said, well, actually, it sounds like a Dravet syndrome, which is important, and we now have a gene to test for it. I tested their gene. It was positive. First of all, they got the label. They always question this, that was it the vaccination? What happened? Maybe our GP gave us the wrong vaccination and our child is in this condition for 20 years. And I was able to, first of all, take away that anxiety from them and say, listen, this is a genetic condition. It is unmasked with fever, and it happens to be that kids get their major fevers when they have vaccination. So, and in that case, we were able to screen the rest of the family for the respect and advise family about that. So, second question was treatment. Dravet syndrome is treated slightly differently than compared to routine epilepsy, and in some patients, this treatment does work magic. So, next time I've seen few cases where I've seen them diagnosed, and 6 months down the line, I see them next. There's 50% reduction in the seizure. They're never seizure free, but at least patients and their family have more information, and they can then be part of combined decision making. So if your patient, which has been described to me by your GP colleague who's respected, then if they're not under adult neurologist, I would suggest that I know it's hard and I don't know complex pathway that you described to me, but try and get them seen by an epileptologist with a special interest in epilepsy. And there are ways in which we can help them. It's just the resources which limit our care provision at every level in UK.
Yeah, well, that's wonderful that you've explained this. And, your explanation is so easy to understand that I feel I could sit here and listen to you all day, which obviously can't be possible. But I've got another, actually, on my personal phone. Somebody's texted me and said, please ask Dr. Hina, what are her thoughts on cannabis oil once we know that the NHS is able to prescribe this?
Oh, this is a question every third patient comes and asks me in the clinic. And cannabis is only used in trials for certain conditions. The license has been discussed and under process of approval for a specific type of epilepsy like Dravet syndrome, like Lennox-Gastaut syndrome. So because the trials are only done for a specific childhood syndromic epilepsy, therefore we don't have license for it to be prescribed for general epilepsy that you, I, or majority of neurologists see. There is no data for me to be able to advise my patient with information backing it to say that it works for general seizure. Saying that, there is some evidence that, to be honest, a lot of 1 in 4 or 1 in 5 patients that come to my first seizure clinic have epilepsy due to drug abuse, and pretty much everyone is taking cannabis. So I do wonder in my mind that why are they having seizures if they are using joints and joints of cannabis every day? But to be honest, this answer is difficult. In general population, for normal kind of epilepsy, it isn't licensed, it is not approved or studied for. The only 2 conditions are the syndromic childhood epilepsy syndromes, in which we can prescribe it on a special request. So it is not for us to prescribe it yet in general practice or routine practice.
Okay, in routine practice. Next question that's come after that follow-up question. Thank you very much for explaining that. Is this something you have ever prescribed?
I have been asked. I haven't had a patient which fits the criteria. There are lots of colleagues of mine who are in the process of prescribing their first or second patient, but we have to then satisfy the criteria. which is, again, I said syndromic epilepsy, Lennox-Gastaut syndrome, which is very, very rare condition. So I haven't prescribed it, but one person after every third or fourth patient I see does inquire about me, and my answer is no. I'm not allowed to prescribe it because there is no trial for this treatment to back up, and give us information in kind of routine epilepsy, someone having 3 generalized seizures per year, or 6 or 7 generalized seizures in 6 to 7 years. These are the people, the syndromic people I'm talking about. They have 50 plus seizures per day, 37 seizures per day. They have atonic seizure, absence, myoclonic seizure, simple collapsing seizure. They are seizing every minute or 30 times per hour. So for them, as a last resort, if we prescribe it, and if they have 13-15% reduction in this seizure, it means something. But if someone only having 4 seizures a year, generalized in nature, or maybe having 6 seizures in 6 years, for them to take regular cannabis oil, I think the risk of addiction to cannabis are higher than actually treating the epilepsy. So that's why the prescription is limited to very, very specific condition, as I mentioned before.
And it's very sensible what you've suggested in terms of weighing the pros and the cons with cannabis, which is relatively new, very under-researched at the moment. Do you think that there is scope for you undertaking a research on this study? I think that you're very capable of doing so, and I wouldn't put it past you, given that a lot of the challenges that you've taken up in life before, and I see you, I follow you, I wouldn't put it past you to embark upon a study like this, Dr. Hina.
Actually, there are lots of studies already ongoing because cannabis is all over in the press, and there's a lots of pharmaceutical interest in that. We as an epileptologist have slightly reserved view on this, whereas pharmaceutical companies are more keen on it. There are actually some other substances which are under research, which I think are more promising than cannabis. But somehow this cannabis thing has taken a lot of social media interest, and there are reports, and people are buying it on the internet. And in America, there are reports of mother, propagating it as a miracle medication and all that. We, as you know, as neurologists and epileptologists, have a huge responsibility, or any doctor dealing any condition have a responsibility to give patient information based on evidence. And because evidence is lacking, we can't just go by single case report or someone coming to media and saying my son has so and so, see, look, he is now walking or talking. We have to have cohort of patients followed up over time, giving this medication, dosing adjustment, side effects, all study for this to come to us, for us to inform our patient, give them that advice, and that's how the process of prescribing goes in NHS. For adult medicine, for general epilepsy, this is not available yet. Yes, for certain conditions there is some evidence, and for which we are happy to help with our patients for prescription. But the way people come and ask, the interest they have, I think it is more. We are not as excited as epileptologists, or we don't have that much information to share with our patient to make that kind of decision. If someone asks me, and I'm just making this remark, that if someone asks me and say, what about going and buying this from Holland and Barrett? I don't say yes or no, and it's your choice to use it, because it is accessible to you. You go and use it, but as a clinician, I won't be able to prescribe it under my name.
Sure, and that's fair enough.
Research is going.
Yeah, absolutely. Well, I can't believe that the time is finished. The time is finished, and we have not completely finished our topic, but it was so wonderful listening to you. I could listen to you all day, and no doubt I will have you on again, hopefully, when you're peaceful and you're at home and you're able to speak to us, because I feel so guilty about making you feel rushed. I really do.
I left myself only in margin of an hour, so I should maybe given myself 2 or 3 hours traveling all the way from the Glasgow, got stuck in Birmingham trying to get to Cardiff. I think it was too much of it's a holiday time, and my husband is holiday enthusiast, so he doesn't want to spend a day at home doing anything. He just wants to travel.
Which is wonderful to have. Well, thank you very much, Dr. Hina, on behalf of Salaam Radio and its listeners and myself, and inshallah hopefully see you very soon.
Thank you so much, my dear.
Thank you. Assalamu alaikum. So that was the wonderful Dr. Hina Abbasi, who spoke to us about very important points regarding epilepsy and regarding cannabis oil towards the end, which is, there's a lot of controversy surrounding cannabis oil, isn't there, about who we can give it to. And she put it there very, very clearly, that people will ask her about it, and every fourth patient asks her, but it is reserved for only those people who have intractable epilepsy or Lennox-Gastaut syndrome, which is a very rare syndrome, and that they have to fulfill a criteria because they have to weigh up all the pros and cons. So yet another show has finished. Inshallah, I will join you again, not next week, but the week after now, for a show related to the medical field to bring you the very best in health education. My dear listeners, it's Dr. Shabina Sidqiyum, and thank you very much for joining me. Assalamu alaikum.